IACM, I extend a warm welcome to all of you. Today is the third of our national online CMEs. The topic this time is fever. The CMEs are being held regularly on the first Thursday of every month from 8 to 9:30 p.m. The main idea behind the CMEs is that the experience and the expertise of the master teachers is available even to the remotest clinicians of our country. I feel honored and privileged to inform you that today we are blessed by the presence of legends of clinical medicine in India who have very graciously accepted to be our guests of honor. They are Dr. K.K. Parikh sir, Dr. P.C. Manoria sir, and Dr. D.K. Hazra sir. Dr. K.K. Parikh sir, past president API and the current president of IACM, needs no introduction at any forum. His presence alone is success to guarantee the success of any endeavor. His inspirational leadership, innovative ideas, meticulousness, and ability to take everyone together sets him apart from every other leader. He is the heart and brain behind these CMEs. I will now request him to say a few words to our association and the participating delegates.
Hello.
Hello. Yes, sir. Please go ahead, sir.
Yes. Thank you, Dr. MP Singh, for your kind words. Good evening, friends. It's really very pleasant and heartening that we are having online CME programs, a part of dissemination of knowledge, which is of Indian Academy of Clinical Medicine. And I would like to put on record and appreciate the work done by Dr. MP Singh for organizing these CME programs, that he has put his all heart in these CME programs to find out the best places, the best topics, the best leaders, best speakers, and everything. So congratulations and compliment Dr. MP Singh for a great work. Good evening, friends. It's my pleasure to welcome the third series of CME on fever, which is a part of dissemination of knowledge program to everyone, even at the remotest place of India, organized by Indian Association of Clinical Medicine. I hope you all are enjoying these online academic programs. We are trying our best to keep the topics of clinical interest, which are very useful in our clinical day-to-day practice. At the outset, I extend my hearty welcome to all delegates who are attending today's program. I also extend my warm welcome to our guest of honor, Dr. P.C. Manoria, who doesn't need any introduction. He is almost heading all the head of the past president of all the associations. He is a great orator. He is a great academician. Dr. D.K. Hazra, retired professor and head of department of SN Medical College, Agra, a great academician, researcher, and a very good human being. We have got very senior chairpersons, legends, Dr. B.B. Rewari, past president of IACM, Dr. Deepanjan, past president of IACM, Dr. Vikas Lumba, professor and head Department of Medicine, Christian Medical College, Ludhiana. Thank you very much for sparing your valuable time for this CME. We have got very learned speakers. Dr. Subhash Chandra Gupta, who is known to all of us. He was past president of IACM. Dr. Raman Sharma. Hello, Dr. Raman Sharma, HOD and professor and HOD, SMS Medical College, Jaipur. Dr. Renu Sehgal, Professor and retired head of the Department of Medicine, SMS Medical College, Jaipur. So I extend my sincere thanks and gratitude for sparing your valuable time for this CME program. Thank you very much. Jai IACM, Jai Hind.
Thank you, sir, for your kind words. It's an honor to be a part of your team. I feel honored in welcoming our next guest of honor, Dr. P.C. Manoria, sir. Sir is former Director, Professor and Head, Department of Cardiology, Government Medical College, Bhopal. He has been past President of API, past President of CSI, and past Dean of Indian College of Physicians. He has been an integral part of IACM since its inception and was the president of IACM in 1996 and 1997, the third ever president of IACM. Sir has been awarded with numerous orations and awards, including the Lifetime Achievement Award in Cardiology by none other than the then president of our country, President Shri APJ Abdul Kalam ji. He has delivered more than 800 lectures and has edited more than 30 books. It is an honor to have you, sir, with us. We'd like you to bless us with your words of wisdom.
Thank you, Dr. Singh. Dr. K.K. Parekh, President IACM. Dr. M.M. Singh, past President IACM. Dr. D.K. Hazra, past President IACM. Dr. B.V. Rewari, past President IACM. Dr. Dipanjan, past President IACM. Dr. Vikas Lamba, Professor and Head, CMC Ludhiana, and Dr. Suresh Kulwa, Secretary IACM. Medical science is a rapidly advancing field where yesterday's fact may become matter for the archives to store, and today's fact may not find agreement with experts of tomorrow. Continuing medical education is therefore an integral part of medical profession. Today's session is dedicated to fever, and I'm sure you will enjoy the flashes of expertise of various speakers during their discourse. I'm sure the proceedings of the webinar will contribute greatly towards better patient care. Thank you very much.
Thank you, sir. It is indeed an honor to have you with us. I will please request you to join us in all our meetings and add to the glory of our association still further. Dr. D.K. Hazra, sir, is not available at the moment. He'll be joining us in another 10 minutes. We'll welcome him after the first lecture. I will now request Dr. Kushwa, sir, Secretary General IACM, to welcome our chairpersons and moderator.
Thank you, Dr. MP Singh. Now, Vikas Lumba. Dr. Vikas Lumba is Professor and Unit Head of Department of Medicine, CMC Ludhiana. He is Organizing Secretary of 2015 IACM Con, which was held in Ludhiana. And he had so many publications and oration in various chapters. So I welcome Dr. Vikas as a co-moderator, and chairperson Dr. B.B. Rewari is our past and he has also many awards in API, IMA, IACM, and Delhi Medical Association, and he is past president of IACM, past editor of journal, our prestigious journal of IACM, which was published from Delhi, and past chairman of the API chapter, API Delhi chapter, and presently vice dean faculty, Indian College of Physics. I invite Dr. B.V. Rewari as a chair. And next, chairperson is Dr. Panjat. He is head of the Department of Medicine, Bengal Medical College. He is member of Bengal Medical Council, former president of 2018-19, and former associate general of JIMA, Journal of Indian Medical Association, and also a member in State AIDS Clinical Expert Panel. I invite Dr. Dipanjan Bandyopadhyay also. Now I request Dr. Vikas Lumba, please start the proceeding. Hello.
everyone. First of all, I would like to pay my respects to Dr. K.K. Parekh, sir. And I will also like to thank Dr. MP Singh, who has put in a lot of efforts to make this CME program a great success. I am sure that everyone is going to be really thrilled and excited after the CME and such a great lectures we are going to have. We are going to be starting with Dr. Subhash Gupta, sir, who is a immediate past president of IACM. And then who is going to be talking on approach to tropical fever, which is very relevant in our scenario. And then we are going to have subsequent topics. So I welcome each and every one of you, and I'm sure everyone is going to be really enlightened after the talk. Thanks, Dr. Kushwa.
So thank you very much for taking this session forward. Respected Professor Parekh, Professor Manoria, Professor M.M. Singh, Dr. MP Singh, Dr. Luma, and a large number of people who are attending this webinar at this hour on a working day. So a great tribute to all of you for and Dr. MP Singh for organizing this. We know that every year different parts of India and other tropical countries are hit by seasonal fevers, especially in the post-monsoon period. And these include dengue, malaria, leptospirosis, typhoid, and some of them have got high morbidity and mortality also. Many times we see that these also lead to a single or multi-organ failure also. What is important is that clinical picture of these diseases is so overlapping that many times it is impossible to achieve differential diagnosis of these diseases in emergency and ICU setting when the time available for intervention is very limited. So we have a very learned speaker to start this session. We have Dr. Subhash Chandra Gupta, who is director of Shri Ram Babu Gupta Heart and Medicine Center, Agra. He has been an ex-assistant professor, Medical College, Muzaffarpur, visiting consultant, Apollo Hospital, Delhi, senior scientific research officer, Department of Medicine. And we know that he has been a past president, organized a very successful IACM Con 2014, critical care in 2009 and 2014. So with these few words, I would request Dr. S.C. Gupta for your talk. Over to you, sir.
Slides.
Dr. S.C. Gupta, sir, please unmute yourself, sir.
स्क्रीन शेयर हो गया सर, अनम्यूट कीजिए डॉक्टर सुभाष, अनम्यूट कीजिए।
Dr. Hari, after the lecture, you can put in your questions in the chat box.
I'll just call Dr. S.C. Gupta on his mobile phone and see what's the problem. Just a minute.
Right.
It started now, right.
Full screen कर लीजिए सर।
Good evening to my elder brother, Dr. Parekh, and my eminent teacher, Professor M.M. Singh. And today's topic is to how do I approach a patient presenting with fever?
Full screen कर लीजिए सर।
Change the screen share.
स्क्रीन करना नहीं आ रहा है।
चलो कोई बात नहीं, चल लेते सर।
Yes, yes.
ठीक है।
Fever,
हाँ,
fever is a physiological response to any infection or inflammation. It is expressed through cytokines storm plus prostaglandins. It can be divided in three major types: fever, which is presented to us less than 2 weeks, that is the acute fever, and fever more than 2 weeks, that is chronic, and fever more than 3 weeks, that is pyrexia of unknown origin. In proceeding,
स्लाइड मूव नहीं हो रही सर। डॉक्टर सुभाष, स्लाइड मूव नहीं हो रही।
sorry sir,
स्लाइड्स मूव नहीं हो रही, आगे नहीं चल रही स्लाइड्स। मूव नहीं हो रही। हाँ, गई तो। एमपी बता। हाँ, यस, गुड।
is it visible?
यस यस, हाँ यस,
Okay sir,
नाउ गुड।
okay sir. As history is as important as in any disease in medicine, so the history is important in the medicine, in case of fever also. First history, we take the FAR, fever, arthritis, and rash. That is typical of viral hemorrhagic fever like dengue, chikungunya, hepatitis B, Lassa fever, Crimean Congo, and so many other arbovirus infections. Rigors or night sweats, even though the patient has not noticed that he is febrile, but it is taken as patient is suffering with fever. And significant weight loss, it means some important pathology is going on which is causing weight loss. Important symptoms are headache and photophobia, that we should think about the CNS involvement. And cough, sputum and pleurisy, the chest infection, viral infection it could be, and localized pain, which is sepsis, superficial or deep, diarrhea, especially bloody diarrhea, that shows some infection like Campylobacter diarrhea, and urinary symptoms, they point to UTI. Next. Coryza and upper respiratory symptoms generally suggest a viral illness. Duration of fever is useful, as I have mentioned, fever less than 2 weeks, fever more than 2 weeks, and fever more than 3 weeks. Examination of the patient is very important. If the pulse rate is more than 125, systolic blood pressure is less than 100, this suggests that patient is seriously ill and immediately be shifted to ICU. Spontaneous hemorrhage suggests a viral hemorrhagic fever, like dengue fever, which is quite prominent in India, and it comes every 3 years. Now in 2024, we are going to face another tide, another wave of dengue fever in the country. Examination is again an important part of practicing medicine. That is the eye examination, which is the anemia, jaundice. It is conjunctival ingestion, like in malaria, leptospirosis, and measles, dengue, and examination of fundus. Fundus examination is important in any case of fever, at least of more than 2 weeks duration. In first, if we want to go for the diagnostic type of CSF, we have to look at for the papilledema and raised intracranial tension, and simultaneously it gives us a picture of bacterial endocarditis in the form of Rothman spots in the boat-shaped hemorrhages on the retina. Examination of mouth, candidiasis, HIV infection, poplic spots in measles, and pharyngitis. Skin examination is equally important. Rash, viral exanthematous, non-blanching meningococcal petechiae, scar or tick-borne rickettsial infection in scrub typhus, and skin sepsis and cellulitis, both in streptococcal infection and in staphylococcus infection. And it is very important to notice the skin infection. Conscious level, orientation, and neck stiffness need to be assessed. Psychosis may be a manifestation of typhoid. I mean, we have to go in the CNS examination also, chest examination, pericardial effusion, pleural effusion, respiratory symptoms, empyema, H1N1 infection, heart murmurs. They are equally important in bacterial endocarditis, rheumatic heart disease, and very, very important. At least I have seen 4 or 5 patients of atrial myxoma in my career. They presenting with the pyrexia for no vision. Examination of abdomen, localized right lower intercostal tenderness suggests amoebicular abscess. This is the most common presentation to me with liver abscess as a pyrexia, fever, and high white count. Hepatomegaly can be in malaria, tuberculosis, hepatitis, hepatoma, amoebic liver abscess. Examination of spleen, splenomegaly can be in malaria, typhoid, HIV, infectious mononucleosis, and lymphoma, leukemia. Examination of ear, typically tympanic membrane. A bully on tympanic membrane is diagnostic of mycoplasma pneumoniae. And examination of cervical lymph nodes is important for EB virus, tuberculosis, cytomegalovirus, lymphoma, toxoplasma, and syphilis. Occipital lymph nodes examination is important for rubella and trypanosomiasis. What do we do? Any patient presenting with fever in tropical country, we have to rule out the malaria first. Malaria and malaria. Malaria film and MP antigen ELISA along with malaria smear. Urea electrolytes, renal failure, liver function tests, C-reactive proteins. Of course, ESR is also equally relevant. Chest X-ray. Before starting any antimicrobial treatment, whether empirical or therapeutic, we have to take the blood cultures for the typhoid, paratyphoid, or sepsis, urine culture, stool microscopy, and culture. Sputum microscopy doesn't help much. Lumbar puncture is necessary if symptoms and signs of meningitis are present. Now, trials for tropical fever. How do I approach acute fever with negative malaria film? If malaria film is negative, however, nowadays we don't get the malaria fever a lot because of the use of artesunate. Even a patient will go and ask the chemist to provide him the treatment for malaria, and he will give the 6 tablets of the artesunate and lumefantrine. I will say 1 tablet twice a day for 3 days, and that's why India is at the moment free of malaria, I should say. I don't see very many patients, hardly 1 or 2 patients in a year for suffering with malaria. But when artesunate resistance will come, and then we will get the malaria fever with resistance to artesunate. In that case, we have to use the quinine. Fever lasting less than 2 weeks, as I have mentioned, fever lasting more than 2 weeks, and fever lasting for more than 3 weeks. Now, causes of fever less than 2 weeks, if there is leukocytosis, it's a very, very important marker that what we are dealing with. If it is leukocytosis, pyogenic infection is good, is there. Leptospira, jaundice, liver failure, renal failure, anemia, relapsing fever. It is tick-borne and lice-borne relapsing fever, Borrelia recurrentris. And this can cause high white count and so many other systemic features, including ARDS. Amoebic liver abscess, pain in the right hypochondrium, fever with rigors. And the most important sign is if you tap the right hypochondrium, the patient will tap on your face. It is so painful. And gout can present with the joint pain and a high white count. If count is normal, fever is less than 2 weeks, malaria film is negative, then we should think of viral infection and it will subside in few days of time. Rickettsial infections like scrub typhus, count is normal or low. And again, it depends with respiratory symptoms. Typhoid or paratyphoid, they also present with less than 2 weeks fever with normal or low white count. Treatment in acute fever is malaria, typhoid, and if they don't respond, then we have to think of the tuberculosis anywhere in the body. In general, at least 50% of the adults, even without taking the treatment, they resolve spontaneously in few days' time. So we should not be hurry in prescribing the antibiotics. In young children and babies, many infections are viral. In adults, even when there is likely to be an underlying cause for infection, it is preferable to delay the anti-infective treatment till the diagnosis is established. Treatment in children with neutrophilia who appear unwell, they are for giving antibiotics empirically. Malaria does not cause a raised neutrophil count. Empirical treatment should be started immediately for meningitis and bacterial endocarditis. So these both are immediate emergencies to deal with. So meningitis, take the blood cultures. Bacterial endocarditis, take the 3 blood cultures. 3 blood cultures, half an hour apart from different sites, and start the antibiotic therapy. Patient with severe sepsis requires empirical antibiotic immediately after a bit taken. Rickettsial infection is often a clinical diagnosis. Patient should be treated with tetracycline. Doxycycline is a very good group of tetracycline antibiotic, 100 milligram twice a day. It should be given either oral or parenteral. Dengue fever should be suspected if there is generalized very severe body pain. Chikungunya, very severe body pain, congestion of eyes, retroorbital pain, and we should suspect the dengue. That is supportive only in dengue, and the fever should not last more than 2 weeks in dengue fever, and classically as saddle pain. Sometimes we discharge the patient with dengue fever, comes back again with the fever just for 2 days. Treatment for pneumonia, although chest X-ray is quite helpful. Chronic fever with neutrophilia, white count. Now, so far, I have discussed about the fever presenting with less than 2 weeks with high white count and normal white count. Now we are going to discuss the fever more than 2 weeks. Chronic fever with neutrophilia, again, deep sepsis. Superficial deep sepsis, we can detect even on clinical examination when patient is presented to us in the acute stage. But we can deal with we can have the patient with deep sepsis, amoebic liver abscess, erythema nodosum. Of course, there are underlying causes for erythema nodosum, like streptococcal infection, like sarcoidosis, ulcerative colitis, oral drugs with sulfa, antifungal, oral hormones, estrogen-like hormones. So erythema nodosum, to check for the erythema nodosum is very, very important clinical finding to streptococcal or the tuberculosis. Cholangitis, fever with recurrent fever, and they subsides of their own or with antibiotic therapy, and relapsing fever. Again, the Borrelia. Borrelia is quite common. Of course, in the lower socioeconomic group, in slums and so many downtrodden state of the society. They are tick-borne. It can be a tick-borne and louse-borne, relapsing fever. Chronic fever with eosinophilia, immediately think of Pichularia bancrofti. Chronic fever with lymphocytosis, leukemia, lymphoma, splenectomy. Very important is infectious mononucleosis, slight jaundice, splenomegaly, lymphocytosis, and whooping cough also presents with lymphocytosis. Chronic fever with neutropenia, malaria, tuberculosis. Chronic fever with normal white count, HIV related, localized tuberculosis, bacterial endocarditis can be with normal white count, chronic meningococcal septicemia, which I have missed quite few patients of chronic meningococcal septicemia because they present with normal white count. Chronic fever with variable white count, tumors, lymphoma, drug reactions, and pyogenic arthritis and tuberculosis. Now, fever more than 3 weeks, pyrexia for neurology. Usually they are not infective in origin. They are not infective, but they are autoimmune disorders or they are tumors, underlying tumors. And important causes are familial Mediterranean fever, which is not quite common in India, giant cell arthritis, that is temporal arthritis, polyarthritis nodosa, polymyositis, dermatomyositis, rheumatoid arthritis. I've seen quite a number of patients, Still's disease, fever, splenomegaly, very high white count, response to steroids only. SLE, a girl presented to me with just few days ago, presented with fever and seizures. Double standard DNA antibodies were done and it came down to be positive. Wagner's granulomatosis, that can be checked on chest X-ray. Malignancy, lymphoproliferative disorders like lymphoma, NHL or non-HL, myeloproliferative disorders, leukemias, and renal and hepatic malignancy. I've seen one of my friends presenting with renal cell carcinoma, RCC, with fever, hepatic malignancy, hepatoma. A patient just few days ago came with a fracture femur, and she was having hepatoma with fever. Common non-infectious causes of fever: lymphoproliferative, myeloproliferative, renal and hepatic malignancy. Fever in HIV infected patients, the likely cause of fever in HIV changes according to CD4 count. How much it is? 200, 150, 100, less than 100, any infection is possible. Like tuberculosis. In HIV, the tuberculosis is of extrapulmonary type. Of course, it is in pulmonary, but extrapulmonary is quite common. Lymphocytic pneumonitis. Fever in early HIV infection may signify underlying pneumococcal pneumonia, tuberculosis. Once CD4 count is below 200, fever may signify opportunistic infection like cryptococcus infection in meningitis and causing meningitis. Non-typhoid salmonella, tuberculosis is common. Pneumocystis carinii, we can be confused with COPD patient because pneumocystis carinii pneumonia presents with hypoxia, shortness of breath, and we should think of pneumocystis carinii in risk behavior patients. Malaria is statistically associated with a higher parasitemia in HIV infection. Late stage HIV infection. Common clinical problems with febrile patients, empirical treatment, what to give if the patient is unwell, empirical treatment. In malaria area, we can have the film positive, but we should go for the ELISA test and we should take the history. That should differentiate, because in malaria, we will never get the high white count. If no response with anti-malarial treatment, we should think of the typhoid fever. And if patient didn't respond in 4 to 5 days time, we should think of tuberculosis. So this is our empirical treatment. First, for malaria, first let the patient subside spontaneously. Let us subside the fever spontaneously in 2-3 days time. Then give malaria, and they don't respond, then typhoid and tuberculosis. Another difficult scenario is a fever which has lasted for more than 3 weeks. That is PUO. CT scan of thorax, abdomen, and pelvis, lymph node, if it is there, then biopsy, and bone marrow biopsy is also important. Common entropics, tuberculosis, osteomyelitis, dental sepsis, hepatoma, SLE, atrial myxoma, they all are the causes of fever of more than 3 weeks origin. Is more common than in adults with PUO in Europe. Finally, there are many other exotic or uncommon infective causes of fever. Some like trypanosomiasis, Borrelia recurrentis, as I said, in relapsing fever, and babesiosis will show up unexpectedly on examination of the blood film. So along with white count, blood film is also important, along with to see other parasites, along with malaria parasite. Others have to be thought to be deliberately sought, such as Bartonellosis, Borrelia, and Q fever. Types of fever, syndromic approach, I will avoid it because this is another angle to see the fever, pyrexia. They present how we can classify it with syndromes like undifferentiated fever, malaria, streptotyphus, leptospirosis, fever with rash, dengue, rickettsial, meningococcal, fever with ARDS, streptotyphus, falciparum malaria, influenza, febrile encephalopathy, Japanese bees, herpes simplex, and even dengue, malaria, febrile encephalopathy. Of course, any patient coming with fever and CNS symptoms, we have to think of cerebral malaria. Fever with multi-organ involvement, like in bacterial sepsis, malaria, and dengue fever, that also presents with multi-organs. Syndrome-based treatment is another angle to look at the fever and how to treat it in emergency situations. Specific infection, streptotyphus, as I said, it's a rickettsial origin. It's a mite. If we rub it on the skin, patient rub it on the skin, and then they present with the streptotyphus. The treatment is either azithromycin, rifampicin, chloramphenicol, or oxytetracycline. Leptospirosis, renal failure, liver failure, high white count, fever, jaundice, and clinical features 5 to 40 days, but can be 72 hours to a month or more incubation period. Biphasic clinical presentation. It can be an ecteric and ecteric leptospirosis and ecteric leptospirosis. Fever, chills, headache, myalgia, abdominal pain, conjunctivitis, sufficient or transient discomfort. Treatment is by, previously we used to give G penicillin for leptospira, but now the third generation ceftriaxone can be given. Dengue, we know Aedes mosquito, it's a viral hemorrhagic fever. Again, headache, retroorbital pain, myalgia, arthalgia, rash, and expanded dengue fever, encephalitis, myocarditis, hepatitis, renal failure, ARDS, and hemophagocytosis. I've never seen a patient yet improving with encephalitis or with hepatic failure. Hepatic failure, I have seen one patient surviving after liver transplant in dengue fever. Treatment is supportive in dengue fever, isotonic fluid. If there is third space fluid loss, albumin, IV albumin, blood transfusion, and if platelet count is less than 20,000, we should give the platelet count. P20 is the formula to take the patient seriously. Pulse pressure less than 20, increase in hematocrit more than 20, and platelet count less than 20,000. We should take it seriously and monitor the patient with P20 formula. Malaria, again, my drug of choice is artesunate. I don't believe in chloroquine or this. Well, it works very well in Indian circumstances, better than quinine even. And let's wait till it is working. And once the resistance will come to artesunate, we will switch over to quinidine, or just possible. It might not appear at all because it has been, artesunate is being derived from kingasu, the herb in China, and it is still being used for last 2,000 years, and no resistance is found in China to malaria in artisanate.
Subhash sir,
Yes, sir.
we are already 25 minutes past.
I think I'm all over. Enteric fever.
Okay, thank you, sir.
Again, first fever, headache, relative bradycardia. Second week, abdominal pain, diarrhea, and constipation. Third week, intestinal bleeding and perforation and moods. Treatment is again with ceftriaxone or by quinolone group of drugs, and sometimes azithromycin and clarithromycin in particular works very well. In summary, fever is a common physiological response to infection, but may also be caused by non-infectious illness. The likely cause can be predicted from careful history, examination of the patient, coupled with knowledge of local pathogens causing fever of short duration, less than 2 weeks or longer than 2 weeks, or even longer than 3 weeks. The diagnosis can usually be clarified further by simple tests, such as the total and differential kind, blood film, peripheral white, and the malaria film. In resource-poor settings, detailed investigation should be reserved for patients whose fever does not settle spontaneously or doesn't resolve after the treatment based on a local algorithmic approach, wider range of pathogens than in the immunocompetent. Thank you very much for patient listening. However, it is a very, very big topic, and I have tried to give the tries 2 weeks, more than 2 weeks, and more than 3 weeks. With white count high, with less white count, with low white count, and with neutrophilia, with eosinophilia, with lymphocytosis. Thank you very much.
Thank you, Dr. S. Gupta. That was an excellent presentation, and given the time constraint, you have justified the topic very well. We have a number of questions in the chat box. May I request the experts to kindly reply to some of the questions in the chat box itself, and the remaining question can be taken up in the end by moderator, Dr. Vikas Lumba. So with these few words, I would hand over to my co-chairperson, Dr. Dipanjan. Over to you.
Good evening, everybody. It's really a pleasure to be on board with all of you. And thank you, Dr. Rewari. Thank you, Dr. Singh. My pleasant duty is to introduce the next speaker. And it's a pleasure to introduce Professor Renu Saigal from Jaipur, who has been a former HOD medicine of the SMS Medical College, Jaipur. Madam is a contributor to several chapters in books, has more than 60 original articles to her credit, and is a fellow of the Indian College of Physicians, the Royal College of Physicians, and the American College of Physicians. Presently, she is a practicing consultant rheumatologist at Jaipur. And may I request Professor Saigal to start a deliberation. Yes, madam, your screen is visible.
Slides are visible, but the full screen is not there.
Good, it is full screen.
So good evening, everyone, and thanks, Chairperson, for introducing me with the kind words. And thanks to Dr. K.K. Parikh, sir, and Dr. MP Singh for inviting me for this CME. I'll be talking about fever with joint pains. We all know the common causes of fever are infections, malignancy, and inflammatory disorders, which form about 30% of all the patients with PO, and they have rheumatic disease and present with joint pains, elevated ESR, CRP, and serum amyloid A, and which is usually present on 3 separate occasions. Now, fever per se, the viral fevers cause joint pains, but these joint pains subside when the fever remites. Now, the causes of fever with joint pains are divided into 3 categories. One is infection of the joints. Second is non-infective inflammatory causes, which has 6 subgroups, and the neoplastic causes. So I'll take the first. These causes can be easily ascertained clinically when we examine the patient from head to toe. And I'll tell you some of the clinical features which may be looked for in these patients. First of all is the oral ulcers, which may be seen in SLE, you see here. Aphthous ulcers, which may be seen in Behçet syndrome. Granulomatosis with polyangiitis, that was previously known as Wagner's granulomatosis. We can have the oral ulcers. Then the photosensitive rashes, which spare the nasolabial fold, and this is seen in lupus. And I shall be grateful if the chats are muted. Then the photosensitive rash involving the nasolabial folds may be seen in dermatomyositis. Then the dry mouth, dry eyes with the Schirmer's test filter paper in the lower fornix showing wetting less than 5 millimeter after 5 minutes. This is seen in primary Sjogren syndrome. Upper respiratory tract involvement is more common in granulomatosis with polyangiitis, that is the Wagner's. Earlier it was called Wagner's. And in EGPA, the eosinophilic granulomatosis with polyangiitis, that is Churg-Strauss syndrome. Earlier it was known as. So in the upper respiratory tract, if any patient has sinusitis for more than 3 months, or otitis media, which is also prolonged, subglottic stenosis, all these features can be present in GPA. It is not moving. Slides are not moving.
Should I ask? उसको कहूं क्या मैं आपको, ये क्या आप चला रही हैं स्लाइड्स, वो चला रहा है?
हाँ सर, मैं कर रही हूँ, लेकिन ये चल नहीं रही, ये आगे मूव नहीं कर रही।
अच्छा, मैं कहता हूँ। हाँ, चालू होगी सर?
जी जी।
हाँ।
Then in granulomatosis with polyangiitis, that is Wagner's, the patient can have a saddle nose and large nasal cavity because of destruction of the nasal septum, strawberry gums. Then the patient may have erythema nodosum, which is tender nodules on the shin. And these are seen in sarcoidosis, tuberculosis, Behçet syndrome, and many others, as the previous speaker, Dr. Subhash told us. Then the bilateral hilar lymphadenopathy the patient can have in sarcoidosis. And the cavitary granulomas can be seen in GPA, that is And the non-granuloma, this cavitary granuloma may be seen in sarcoidosis also. Then uveitis may be seen in sarcoid, Behçet's syndrome, and in Behçet's syndrome, posterior uveitis is also there, which can be seen on fundus. Then in GPA, the nodular scleritis, sclerokeratitis, exophthalmos may be seen. And these eye symptoms are more than the microscopic polyangiitis and equal to the eosinophilic granulomatosis with polyangiitis. Pulmonary renal syndrome, where we have renal failure along with the diffuse alveolar hemorrhages, which are seen like this in CT scans, may be seen in pulmonary renal syndrome, may be seen in GPA, microscopic polyangiitis, and lupus. Other causes are also there, but since I am restricting myself to the fever with joint pains. Then this I have already discussed. Then monoarthritis may be seen in septic arthritis, then tubercular, sorry. Then in the tubercular arthritis, fungal arthritis in gout or pseudo gout. Oligoarticular involvement may be seen in reactive arthritis. That is, oligoarticular means 2 to 4 joints are involved. Polyarthritis may be seen in rheumatoid arthritis, SLE, adult onset Still's disease, subacute bacterial endocarditis, viral arthritis, also in gout. Serositis, that is pleuritis or peritonitis, may be seen in SLE, adult onset Still's disease, and familial Mediterranean fever. We have the fleeting or migratory arthritis. This is seen in acute rheumatic fever, gonococcal arthritis, Whipple's disease. Urethritis is seen in gonococcal arthritis, reactive arthritis, and carditis is seen in rheumatic fever.
अभी ये रेणु सहगल बोल रही है, बहुत अच्छी बोल रही है.
Rash may be seen during the febrile episodes, as in adult onset Still's disease and familial Mediterranean fever.
पारिक सर आप अनम्यूट कर लीजिए. पारिक सर,
तो मैंने कहा ठीक है.
सर पारिक सर, यू आर अनम्यूटेड, प्लीज म्यूट योरसेल्फ सर.
और ये 100 तो हो ही जाते हैं ना, 100 150 100 सवा 100 तो हो ही जाते हैं.
Should I continue?
Yes, ma'am, please continue.
The pain abdomen may be seen in polyarthritis nodosa and familial Mediterranean fever, where there is peritonitis, and also in Schorlin or IgA vasculitis. So these are the pain. Then we have a number of investigations which can be I can discuss in the subsequent slides. So we start with the infections. Fever with joint pains. Start with the sir. Parik sir, please.
मैं फोन करता हूं सर को.
जी. So infections. First, I will take infections. Infections, septic arthritis. It is caused by Staphylococcal aureus or Streptococcus, and the gram-negative bacilli may also cause the septic arthritis. Now, gram-negative bacilli usually affects older adults or immunosuppressed adults, and there is IV drug users, or it may be secondary to trauma. And here the patient may be febrile. While in cases of the gram-positive involvement, the streptococcal infections, patient is febrile. There is acute single swollen joint, warm, restricted movement. But in 20% of the patients, oligoarticular or polyarticular involvement can occur. And knee involvement is seen in more than 50%. Wrists, ankle, and hips are also commonly affected. Synovial fluid will show the leukocytes more than 20,000 per cubic millimeter, mainly the neutrophils. Gram stain and bacterial culture is also positive. In gram-negative, we'll find gram-negative bacilli. Then other infective arthritis are bacterial endocarditis. The patient presents with fever, rash, arthritis. Rheumatoid factor may be falsely positive. And the blood culture from 3 different sites will give positive results. And response to antibiotic is the clue to diagnosis, because arthritis will subside after giving antibiotics. The gonococcal arthritis, there is migratory arthritis with fever and scalding micturition. Then tubercular arthritis, the fever may be absent or it may be subtle. Monoarthritis is there with pain, stiffness, and loss of function, which may be there for weeks or months. Synovial hypertrophy causes boggy swelling with or without warmth. and these are the commonly involved joints. The radiological evidence of juxta-articular osteoporosis, marginal erosions, and joint space narrowing may be seen. This is known as Pemister triad, and this annual biopsy and nucleic acid amplification test may be positive. The fungal arthritis is again indolent monoarthritis, and it is usually seen in immunocompromised hosts. Signs of inflammation are present. Permanent damage to joint occurs. So this is very dangerous type of infection. Infection through the contaminated prosthesis, contaminated IV or intra-articular injections, or through hematogenous routes can occur. The common fungal infections are Candida, Aspergillus, Xerohilum fungus, which caused outbreak of this fungal arthritis in September 2012 because of contamination with the methylprednisolone acetate with the Xerohilum rostratum, and 13,000 patients were affected, and there were 55 deaths. Viral arthritis, we all know there is a sudden onset fever, symmetric polyarthritis, and it usually subsides in 6 weeks. While the chikungunya arthritis may persist a little longer, a few months, and sometimes even longer, and the pruritic rashes are there in chikungunya. The IgM antibody appears 2 to 3 weeks after the onset of fever, while PCR may be positive in the early stage. Then other viruses like Zika, Parvo B19 virus, where it is, the child has slapped cheek syndrome, as if someone has slapped the cheeks, and hepatitis B and C in the pre-pricked phase may present with fever and arthalgia. Rubella virus, rubella vaccine also can cause fever and joint pains. And Epstein-Barr virus, these are the other causes of viral arthritis. Again, there is problem. Then the Whipple's disease is a rare, Whipple's disease is a rare systemic disease which is caused by the bacterium Proferima epilae. And here the abdominal symptoms are there, like diarrhea, weight loss, and associated there is relapsing seronegative, non-restrictive migratory arthropathy and fever. In some patients, joint symptoms, antedate GI symptoms, and biopsy of the colon clinches the diagnosis. So this is a rare disease, not a very common disease, but patient can present with fever and joint pains. Now we come to the non-infective inflammatory causes. First and foremost is autoimmune rheumatic diseases. Now, SLE, the patient, I used to teach my residents that remember foam, that is fever, oral ulcers, alopecia, arthritis, and malar rash. So these are the cardinal symptoms of SLE, and the malar rash is photosensitive and sparing the nasolabial fold. I showed you in the previous slides. Serositis, nephritis, CNS involvement can occur. The patient can have the alopecia and discoid rashes. Then leukopenia, lymphopenia, anemia, thrombocytopenia. Now, fever in lupus patients may be either because of the flare, where the CRP is normal and leukopenia is there. And infections are very common in SLE. So patient can have high CRP and normal or high TLC. So this is very important to differentiate because the treatment is entirely different. Then certain antibodies, anti-dsDNA, the anti-SM antibody, low C3, C4, and anti-phospholipid antibodies can make the diagnosis. Then we come to the primary Sjogren's syndrome. There is autoimmune destruction of salivary and lacrimal glands and dry eyes and mouth, Shermer test I told you, and then positive SSA, SSB, and anti-Rho52 antibodies. This labial biopsy will clinch the diagnosis. There will be lymphocytic infiltration, destruction of the gland, and the primary Sjogren's syndrome has typical polyarthritis, and usually fever is absent, but if fever develops, we should suspect lymphoma, which is very common in patients of primary Sjogren's syndrome. Then we come to the idiopathic inflammatory myositis, the proximal muscle weakness, constitutional features like fever, arthalgia, weight loss, high CPK, LDH, and aldolase, and MRI will show this the white, you see inflammation of the muscles. This whitening is there, and this MRI will pick up this inflammation of the muscles. Then other connective tissue diseases like the patient can present with Raynaud's phenomena and the positive ANA and arthalgia. which are the hallmark of connective tissue disease, and mixed connective tissue disease, anti-1 RNP is positive, and the patient has the features of SLE, systemic sclerosis, and polymyositis with low-grade fever and arthalgia. Then rheumatoid arthritis, we seldom see fever in these patients, and we all know how to make the diagnosis, but fever may be there if there is flare of rheumatoid arthritis. We see this flare in many patients. Despite DMARDs, the patient can have flare. And associated vasculitis, Felty's syndrome, where there is associated lymphadenopathy, splenomegaly, neutropenia, susceptibility to infections, ulcers, and rheumatoid factor is positive. Large granular lymphocyte syndrome is also may be seen in rheumatoid arthritis when there is neutropenia, infections, and splenomegaly may be positive or negative. Then the second group is post-infectious in the non-infective inflammatory group. The reactive arthritis, there is oligoarthritis, which is asymmetric additive, arthritis involving the lower limb joints, and develop after the non-gonococcal urethritis or gastroenteritis. The fever may be present rarely in the early phase of disease where GIT symptoms are still present. Cercinate balanitis was seen in one of my patients, so I had the picture of this. On the glass may be seen post-genitourinary reactive arthritis. Concets arthritis is para-infective arthritis in patients with active extrapulmonary tuberculosis. There is usually tubercular lymphadenitis. Patient presents to us with acute or subacute reactive polyarticular joint involvement of large joints without invasion of the joint cavity by the tubercle bacilli, and it may the patient may present to us with fever and malaise, positive Montauk, and ATT resolves the arthritis. These are the features. Acute rheumatic fever, I'm omitting because everyone knows about the rheumatic fever, Jones criteria, etc. Non-infective inflammatory, third group is the crystal arthropathies. Usually patient has monoarthritis, first MTP is involved, though the oligo and polyarticular involvement can occur, and polyarticular gout is more common in postmenopausal women. And few of the patients may present with fever, more so if more than one joint is involved. Attacks subside in 1 to 2 weeks. High uric acid is found in many patients, but normal uric acid does not exclude gout. Joint aspiration will show needle-shaped crystals of monosodium urate, which may be seen in low-power microscope. And there will be negatively birefringent crystals under polarized light. This figure we took from the mobile from one of my patients, and you see here the needle-shaped crystals under low-power microscope are easily seen. So we can go for it rather than waiting for the polarized microscope. Then we come to the calcium pyrophosphate dihydrate crystal deposition disease. In 50% of these patients, patient presents to us with fever. There is monoarthritis of the large joints in elderly. So any patient of osteoarthritis who develops the flare, we should suspect CPPD disease, and aspiration will show envelope shaped crystals which are positively birefringent. I will tell you what is positively and negatively birefringent. The chondrocalcinosis of wrist or knee joints may be seen. This is in one of my patients who presented to me with the rheumatoid-like picture. X-ray showed triangular cartilage was calcified, and here also you see the cartilage of the knee joint was calcified. This is known as chondrocalcinosis, and this is the polarized light axis. Anything which is parallel to it will be yellow, and this is needle-shaped crystals, and it is called negatively birefringent. And if it is perpendicular to the polarized light axis, it is blue. So this is negatively birefringence, and the calcium pyrophosphate crystals P that is positively birefringent, because if it is parallel to the light axis, it will be blue. If it is perpendicular, it will be yellow. So just the opposite of monosodium urate. Now we come to the third group, that is vasculitis group. Now vasculitis, large vessel vasculitis, giant cell arteritis, patient is more than 50 years. Suddenly he has no new onset headache, temporal artery is thick and tender, and the inflammatory markers are raised. Then hypoechoic halo, which I'll show you. This is hypoechoic vessel wall, which is because of edema of the vessel wall, and this is so typical of giant cell arteritis. Then the temporal biopsy showing focal granulomatous inflammation, but skip lesions are there, so a biopsy may be falsely negative. So we should not much depend on the biopsy unless and until we have taken 1 centimeter piece of the temporal artery. Low-grade fever can occur in 1/3. Joint pains can occur in 25 to 60%, and it involves the shoulder and pelvic girdle, neck or torso, which is consistent with the polymyalgia rheumatica. Then we have Takayasu arthritis, another large vessel vasculitis. It is also a granulomatous arthritis, seen more in Asian ethnicity. Aorta and its branches are affected. The patient's age is less than 60. Earlier it was less than 40. Now it is less than 60. Criteria is less than 60, and it is more common in females. In pre-pulseless phase, the patient can present to us with fever, fatigue, arthalgia, weight loss, and fatigue. Fatigue is first. Then pulseless disease, the patient, second stage is pulseless disease, where the limb claudication, reduced peripheral pulses, subclavian or renal artery stenosis, the renal artery stenosis can produce bruit, and left subclavian artery is more commonly affected. CT angio will show narrowed upper limb and renal arteries. Then we come to the necrotizing vasculitis or medium and small vessels, that is polyarthritis nodosa, fever, cutaneous involvement, articular symptoms in 50% of our patients. The patient can have gangrene, renovascular hypertension, postprandial abdominal pain, melena, stenosis of the celiac arteries or visceral arteries, and microaneurysms may be found. This is in one of my patients. There is gangrene of the lower limbs. The hypertension was there, leukocytosis, then high ESR, and CT of the angio of the abdomen showed the left renal artery stenosis and stenosis of the celiac trunk, and stenosis of femoral arteries also. Then we come to the ANCA-associated vasculitis, which is small vessel vasculitis, and you see here there is a constitutional features present. Diffuse alveolar hemorrhage, I showed you the slide. Post-immune glomerulonephritis, which presents with proteinuria, hematuria, hypertension, and renal insufficiency. You see leukocytoclastic vasculitis, which presents as palpable purpura. Mononeuritis multiplex, when there is sudden foot or wrist drop, and this occurs because of vasa nervosum involvement, small vessels. Then in GPA, I told you the otitis, sinusitis, subglottic stenosis, cavitary lesions, and C-ANCA will be present on immunofluorescence, but we prefer to go by the ELISA, which is anti-PR3 positive. So first we will go for the anti-PR3 by ELISA. Then we come to the microscopic polyangiitis. These symptoms are more or less same as GPA, but the nasopharyngeal involvement is absent, and the anti-MPU ELISA is positive. Then we come to the immune complex mediated small vessel vasculitis. Now we have the IgA vasculitis, which was previously known as Hinoch-Chonlin purpura. The patient presents to us with various organ involvements, skin, GIT, and joints, rarely lungs. More benign in children than in adults. It may be in adults causing sequelae, renal failure. The fever is there, skin rashes on lower limbs are there, which is the hallmark of this disease. Pain abdomen, bloody stools, joint pains, knees and ankles are involved. Then edema can be there, and biopsy will suggest IgA deposits in the leukocytoclastic vasculitis. And this we have to demonstrate by the immunofluorescent studies. Then cryoglobulinic vasculitis, the patient has cryoglobulins and complement in the vessel wall. Various organs are in the manifestations like Raynaud's phenomena, cold-induced acrocyanosis, livedo reticularis, urticaria, ulcers, fever, joint pain, renal involvement, neuropathy, low C4, and increased cryoglobulins may be there. This is usually secondary to hepatitis C infections, but chronic infections, lymphoproliferative disorders may be there underlying in the setting. And autoimmune diseases can also have the cryoglobulinic vasculitis. Then we have the variable vessel vasculitis, the Behçet's disease. It is seen more in the Mediterranean, the people of Mediterranean ethnicity. Small, medium, or large vessels are involved. Urogenital ulcers, erythema nodosum, arthritis, thrombosis, aneurysm formation. Thrombosis may be either venous or arterial. Patient presents to us with fever. HLA-B51 is positive. And so I showed you the aphthous ulcers, and this is scrotal ulcer in one of my patient where the scrotal ulcer was there, and this was the oral ulcer. So urogenital ulcers can occur. Then we come to the autoinflammatory syndromes, the adult onset disease and systemic onset GIA, juvenile idiopathic arthritis. They are just similar. It is a diagnosis of exclusion. If these things occurs before the age of 16 years, then it is called systemic onset GIA, where fever is there. And there are elevated ferritin more than 1000 nanogram per ml and very high levels up to 30,000 nanogram per ml may be found. In the systemic onset, arthalgia will be there in the early stage. Later, the arthritis can occur. Now, this is Yamaguchi criteria of adult onset stage disease. The patient has arthalgia more than 2 weeks, arthritis, knee, ankle, and wrist can occur. Fever more than 39 degrees Celsius, intermittent fever is there. Fever remains there for 4 to 6 hours in a day for more than 1 week. Typical rash, salmon pink on trunk and extremities may be seen. Leukocytes more than 10,000 with neutrophils more than 80%. Sore throat, lymphadenopathy, splenomegaly, liver function tests, which are abnormal, negative, rheumatoid, and ANA are very important. And it is an exclusion diagnosis of exclusion. You should exclude infections, malignancy, other rheumatic diseases. Now, this is total criteria of the same disease where the glycosylated ferritin less than 20% has been added. In a patient of adult onset, if you find pancytopenia, you should be alerted that the patient has developed the macrophage activation syndrome.
Dr. Renu, sorry to interrupt, but we are running short of time. We have one more speaker. Can you conclude, please?
Okay.
Next 2 minutes.
It is, I'm frustrated with the, it is not moving ahead. So how much time should I take? I should stop?
Maybe 2 minutes more.
Okay, okay.
Thank you.
Then we have, I'll go by this only, the small, not the full screen, okay? Then we have the miscellaneous group, sarcoidosis. I told you about the non-visiting granuloma fever, and this is very clear. Then the macrophage activation syndrome, where the patients with rheumatic disease develops pancytopenia and hyperinflammatory state, and multi-organ failure can occur with low fibrinogen, high ferritin, and triglyceride levels. So this is the bone marrow biopsy is diagnostic. Certain drugs can cause fever and joint pains are there. So sulfasalazine, allopurinol, TNF inhibitors, they can produce the fever and joint pains. In 5% of the patients, TRAS syndrome, that is drug rash and eosinophilia with systemic symptoms will be there. Then we come to the neoplastic. Neoplastic, we have the malignancy in children. The patient there is refusal to bear weight on a limb in lymphoreticular malignancies in children. Severe pain on compressing the mid femur or humerus is there, and joint swelling is fleeting. While in systemic onset GIA, the patient can walk short distances, swollen or painful joints are there, non-fleeting joint pains are there, and there is severe tenderness over joints, which is lacking in these patients where it is present here in the lymphoreticular malignancies. There, the PBF or the counts will tell us the diagnosis. Neoplastic carcinomatous polyarthritis, this patient presented to me with polyarthritis, and there was palmar fasciitis with the flexion deformities. And this is typical syndrome of palmar fasciitis with polyarthritis. The patient has non-deforming, non-erosive polyarthritis. There is absence of subcutaneous nodules, negative family history, and poor response to steroids and DMARDs, which distinguish it from the rheumatoid arthritis. So it may be seen in number of carcinomas. This patient had lung carcinoma. So the take-home message is fever with joint pains may be because of infections of the joints, non-infective inflammatory diseases, rarely carcinoma, present with fever, joint pains, and arthritis, and false positive serology. A very good history, physical examination, and investigation should be done to diagnose these diseases. And thanks a lot for the your attention, and thanks.
Thank you, madam. And I think that was truly in the spirit of the IACM. We had a wonderful panorama of cases, and we could revise ourselves apart from our juniors. I think we revised what could be the variety and the spectrum of presentations that fever can present with to a rheumatologist. I think we should move on to the next speaker and take the questions if there be any at the end of the session because of.
Sir, I'd like to interrupt for a minute.
Yes,
Professor Dr. D.K. Hazra sir has joined us. It is an honor and privilege to welcome Professor Dr. D.K. Hazra sir. He is our guest of honor tonight. Sir has been former Director Professor and Head PG Department of Medicine, Medical College, Agra. His academic achievement, awards, and contributions to the field of medicine would require a CME of their own. He is the pioneer of nuclear medicine in India and is the world authority. He was the one to invent the TSH assay in 1975 and the first one to use radio-labeled antibody for cancer therapy in 2000. He was awarded with Padma Shri in 2014 by the Government of India for his contributions to the field of medicine. Sir has also been a president of IACM in 2008 and 2009. Sir, it's an honor for us to have you amongst us. Please enlighten us with your words of wisdom for a minute or two.
I think your efforts to to take clinics in this manner is commendable, and all I would say is that they should be followed up by a small booklet giving an account of all the conditions which were mentioned, because it is impossible, I think, to absorb all of that in a one slide viewing time. So perhaps a small booklet would be extremely useful to the participants. Thank you all, and thank the IACM for giving me this opportunity. Thank you so much.
Thank you, sir. We'll make sure that your suggestion is followed up.
Yes, sir. Thank you. Dr. Singh,
Good evening, everyone.
the next speaker.
Yes, sir. Sure.
Good
Please
evening,
go ahead, sir.
everyone. It's my honor and privilege
Yes,
to call
Dr.
upon the
Lumba.
next speaker. Yeah, good evening, everyone. It's my honor and privilege to call upon next speaker, who is none other than Dr. Raman Sharma, who is the head of department of SMS Department of Medicine at SMS Medical College. He has got a lot of things to his credit. He has got publications in very important journal like Lancet, and he has been a president of APA also of Rajasthan chapter, and he is active into various associations. Before taking any more time, I would request Dr. Raman Sharma to start his presentation, please. Thank you.
Good evening, everyone, and I'm extremely thankful for inviting me to this August conference, which is going online. And I would be talking on dengue fever and complications of dengue. So dengue fever, it's responsible for an estimated 100 million symptomatic cases of infection out of total 390 million of infections, and is responsible for 10,000 deaths annually. So that is really a very, very enormous figure as far as deaths in tropical countries is concerned. So it's the most prevalent arthropod-borne disease. It is caused by a flavivirus, and it's an ancient disease. It was documented from 1779 and 1780, and has recently shown in last 40 years a 30-fold rise in the number of cases. There are 4 serotypes we already know, which are basically transmitted primarily by the bite of Aedes, and the other is Albopictus. So risk of disease is higher with areas having multiple endemic serotypes. That is important to remember. Asian genotypes are DEN-V2 and DEN-V3. They are responsible for severe disease and epidemic dengue hemorrhagic fever. We did a study of serotyping in 2015, and what we found was that out of 18 cases, 10 were DEN-3 and 6 were DEN-V2. The current serotype which we typed was in November 2021, and 15.38% were DEN-V1, and most of these belong to DEN-V2 category serotypic, 72.30%. DEN-V3 was 6.15%. However, whenever there is an attack of dengue fever in a community, it's a closely knit community. So the secondary attack rate may reach up to 50 to 70%. That's an enormous figure. I'll quote the DNA article, mosquitoes are the deadliest predators. Of course, the problem here is that they are uncaged, and that's the problem. And they are found in every region of the world except the Antarctica. And these are the two mosquitoes responsible for dengue fever, the Albopictus tiger mosquito. So these are the WHO defined deadly mosquito-borne diseases: chikungunya, Zika virus, because of the complications to the newborn. And of course, EDs can cause dengue fever, yellow fever, malaria, and West Nile virus. So again, from WHO, these are the deadliest animals in the world and responsible for a horde of infections. So these are the two mosquitoes which are responsible. And this is a figure from Cuba, 1997 epidemic. You can see here approximately 70% of the cases are subclinical. And out of these, 29% may progress further with symptoms of fever. And out of these, 4% would land into dengue hemorrhagic fever and dengue shock syndrome. There were about 12 fatalities out of these pool of infection, giving a figure of 0.2%. So this is what is known as the iceberg characteristics of dengue fever. And this is a classification which is still important to remember. Dengue fever, it's mostly primary direct infection. And the complications occur when second serotype infects the humans. And we already come across a lot of cases which are unclassified. You really don't get the test as positive, but maybe they are unclassified or intermediate dengue infections. However, in WHO 2012 revised the classification into dengue fever and severe dengue. So it's easy to remember, but the previous classification was also very important, which was done in 1997. And this is our statement from SMS Hospital. You can see here, 2004, we started compiling the data, and there is a steady increase. And 2022, there was a tremendous increase. And the total mortality was around 1.17%, which matches the textbook mortality. And of course, you all know that we get extremely critical cases in our setting. And what are the risk factors of dengue fever? Basically, these are divided into individual risk factors, epidemiological risk factors, and viral factors. So basically, humans are the reservoir. So age, children, and young adults, sex, dengue can be found in most of the men and women, almost equal incident. Race, of course, certain races are particular. In Southeast Asia, we do get a lot of cases. Nutritional status is important. Malnutrition predisposes, and of course, presence of secondary infection. And everything depends on the host response as well. So what are the epidemiological factors? Number of susceptibles present in a community, high vector density, wide viral circulation, and hyperendemicity. What is hyperendemicity? When two or more types of when there are multiple dengue serotypes are circulating in a community, this is what is known as hyperendemicity. And of course, strain virulence and serotype are also important. And this is a beautiful picture from New England Journal of Medicine depicting the antibody-dependent enhancement. This is the basic pathogenesis of dengue fever. A new serotype virus partners with IgG due to a previous dengue infection, leading to enhanced cytokine storm. We have seen cytokine storm in H1N1 and of course during the COVID time. So this is the viral infection, and this is the basically endothelial cell. The basic pathogenesis is that a lot of outpouring of cytokines is there that leads to accumulation on inflammatory mediators inside the vessel wall, causing thrombocytopenia, increase in the vascular permeability. So that is basically responsible for the complication. And of course, the NS1 antigen, it modulates the glycocalyx and possibly it also releases the heparin sulfate, which is responsible for the endothelial damage. It's important to know the clinical features. It has a febrile phase, it has a critical phase, and of course the recovery phase. Most of these patients recover. So febrile phase, the incubation period is 7 to 10 days. The average duration it lasts is 5 to 7 days, associated with retroorbital pain, myalgias, back pain, polyarthralgias, what is known as breakbone fever. And rash, of course, is centrifugal in distribution. It could be erythematous, it could be urticarial, scarlatiform, associated with palmoplantar edema and pruritus. And these are the various rashes taken from our patient. This is the measly rash of dengue. This is the palmar erythema and erythema. This is the urticarial rash, and this is the disseminated petechial rash and dengue hemorrhagic fever. And of course, one characteristic feature is that there is a spading of skin islands of white. You can see here the white spots here. So this is quite characteristic of dengue fever. Now, this is an old classification, but is very useful. And this was from medical clinics of North America. So dengue hemorrhagic fever, this is the critical phase now. The untreated mortality is mind-boggling. It's 10 to 20% for a disease which is easily treatable. So that should be a history of fever or fever ongoing. Thrombocytopenia, the platelet count less than 100,000, hemorrhagic manifestation, and evidence of plasma leakage. Plasma leakage is more specific than the hemorrhage. So the evidence of plasma leakage is that there is an increase in hematocrit by more than 20%. There is hypoproteinemia and presence of effusions like ascites, perigV edema, pleural effusions, etc., etc. So if we combine these clinical features, so the sensitivity of dengue will be around 90%. So clinically, you can diagnose on the basis of these symptoms and signs to a tune of 90%. Now, again, going to if the critically ill patients further progresses, the mortality of this can reach to 20 to 40%, and the most dreaded problem is the shock syndrome. The systolic blood pressure is less than 90, narrow pulse pressure is there, accumulation of fluid is there, presence of severe bleeding, OTPT elevation of 1,000. We have seen many patients of having getting anectic hepatitis and transaminitis of thousands and thousands. A neurological involvement, acute kidney injury, or multi-organ dysfunction syndrome. Dr. Gupta already described about this dengue syndrome, expanded dengue syndrome. This is basically a direct invasion of the vital organs, and this syndrome includes patients with severe organ involvement, liver, kidney, brain, heart, but without evidence of plasma leakage. Now, these are the figures from 1981 and 1997 figures of fatal cases from Cuba. You can see here, fever was present in most of these cases. And two important things, the shock was present in 100 out of 100 fatal cases. Hemorrhagic manifestation in 55%, but later on, 1997, 100% of. At that time, no neurological involvement was there. So I think this could be a new development, that direct invasion of the neurological structures is by current serotypes. Always very important to remember the warning signs. And what are the warning signs? Abdominal pain plus tenderness, persistent vomiting, abrupt change from fever to hypothermia, particularly in children. Clinical fluid accumulation is, of course, indicating a severe disease. Mucosal bleeding, lethargy, restlessness, hepatomegaly, increasing hematocrit and decreasing platelet, decreased urine output. So this is again the classification I've already told you: dengue plus minus warning signs and severe dengue. Again, coming to the clinical course of a dengue hemorrhagic fever, we can see here there is a febrile phase and there is a critical phase on day 7 onwards. When the patient becomes serious, you can see here the blood pressure narrows down, the pulse pressure narrows down to 100/90 from a blood pressure of 120/80. And of course, if you treat properly, the hematocrit would restore to normal, and important treatment modality is just give fluids. So diagnosis of dengue fever is very important, and basically depends on the stage at which you intercept the disease, the infection. So stage 1 is fever and viremia, accompanied by NS1 antigen in the blood, which is a rapid, sensitive, and specific method, NS1 antigen. The sensitivity of NS1 during febrile phase can exceed 90%, but it can be lower, up to 70% in secondary dengue because of presence of cross-reactive NS1 antibodies that impede detection of free NS1. So we must remember that the sensitivity is not very high when there is a previous infection. Stage 2 is early post-febrile period lasting a few weeks when IgM and IgG antibodies are in excess. So ELISA is a very sensitive test, 90 to 90% sensitivity is there. It is detectable after 5 to 6 days and lasts for 2 to 3 months. False positive ELISA can be there after yellow fever vaccination or Japanese encephalitis vaccination. However, the IgG lasts for lifelong. Again, this is, as I told you, diagnosis depends on duration of fever and test positivity. This is another way to represent it. And this is the NS1 antigen on day 1 to day 7. And later on, after day 4 or 5, the IgM antibodies start appearing. Now, coming to the management. For a disease that is complex in its manifestation, we have already noted down the complication, the manifestation. Management is relatively simple, inexpensive, and very effective in saving life, so long as correct and timely interventions are instituted. Now, what are those? Why are they needed? What are the aims of treatment? We have to assess the severity of dengue infection. Assurance, the usual clinical outcome is good. Intercept the progression early by prompt fluid replacement, use of blood, plasma, or platelets in patient with falling hematocrit or continuous bleeding should be considered. Important thing is that patients have fever for a few days, and this is the typical Saddleback fever, biphasic fever. Paracetamol is safest, not exceeding 6 doses per 24 hours. No IM injection should be given. Orally, if the patient can tolerate, you can use fruit juices, ORS, rather than plain water. And clinical management, the most important key feature is to identify the pre-shock stages so that the complications are averted. And this is identified by warning signs. So why is there a need of IV fluids? Because plasma volume is reduced. Volume loss may be up to 20% because of the leakage syndrome. Total fluid requirement per day is very simple formula, 1500 ml plus 20 ml per kg for each increase in weight of 20 kg. Maintenance fluid should not exceed 3 liters per day. What are the signs of overhydration? If we give excessive fluid, rapidly falling hematocrit, wide pulse pressure. Type of fluid, most important is normal saline or ringer lactate. Initially, NS is preferred, but if hyperchloremic acidosis occurs, use of ringer lactate is advocated. Again, if there is lactic acidosis, use ringer acetate. Glucose saline can be used, particularly in children when the glucose falls to less than 80 milligram. The initial infusion rate should be 6 ml per kg per hour. Watch for recovery by timely pulse rate, blood pressure, hematocrit 8 hourly, and urine output. No improvement, then increase the fluid intake by 10 ml per kg in 12 and 20 ml per kg per hour. So this is very important to avoid complication. If there is still no improvement, consider use of colloids. However, if the patient improves, then you have to reduce the frequency of fluid administration to 3 to 5 and then 2 to 3 ml. Of course, if there is vomiting, diarrhea, dehydration, you have to compensate for fluid intake. So there are two parallel bars here. One is increased hematocrit and the other is decreased hematocrit. Increased hematocrit means there is the capillary leak syndrome is prominent. You can use FFP if fluid is not, the patient is not responding to fluid. The dose is 10 to 12 ml per kg. Plasma substitutes 5% albumin or dextran. If the hematocrit is decreasing, you need to transfuse RBC, packed RBC or whole blood transfusion because it indicates that some internal bleeding is going on and the dose is 10 ml per kg. Whole blood can be used in double the dose. Platelets of SDP and particularly single donor platelet, if platelet count is less than 10,000. The good thing about dengue fever is the vascular integrity usually is restored within 48 to 72 hours. What is the role of antivirals? None. It's a disease which was described in 1768, but still there is no antiviral here. Steroids, please do not use steroids. Increase in the GI bleed is there and it's not recommended. Do not use artesunate because it can also lead to delayed hemolysis or artesunate resistance. Electrolyte imbalance must be corrected. Use of antiemetics is permitted, antihistaminics, of course. Antibiotics like cefiperazone should not be used. We are not using any antibiotics in a confirmed case of dengue fever. So, of course, cefiperazone is associated with coagulation abnormality, and the incidence of gram-negative sepsis is only 0.5%. A patient of dengue with 20,000 platelet count might not be bleeding, whereas patient with 60,000 to 80,000 might be bleeding. This could be due to platelet dysfunction. What are the causes of thrombocytopenia? Bone marrow suppression, anti-NS1 antibody-mediated cytokine adherence to the endothelial membrane, immune complex mediated, macrophage activation, complement mediated, or presence of DIC. And what are the causes of bleeding? Thrombocytopenia, platelet dysfunction and sequestration, prothrombin defect, endothelial injury, DIC, low fibrinogen, raised FDP, and raised D dimer. So these are the features. As I told you, bleeding, if continues and the platelet is falling to less than 10,000, we can use platelet transfusion. Difference between RDP and SDP I have enumerated. So one unit would raise the platelet count by 5,000 to 7,000. So you require 5 to 6 RDPs as compared to a single unit of single donor platelet RDP. And this causes exposure to multiple donors, and there is less immunogenic exposure. And one SDP unit would raise the platelet count by 30,000 to 50,000. This is the storage of platelets. Should not be refrigerated. This is very important. The residents sometimes do put it in the fridge. So platelet count increments after transfusion may be lower than expected in the presence of certain medication like use of amphotericin, presence of ongoing fever, splenomegaly, infection, or previous ITP. Many patients we come across platelet count so is not improving despite of giving platelet. This is the non-responsiveness to the therapy. So under previous history of ITP, chronic ITP should also be taken. Alloimmunization to HLA or other antigens. FFP, of course, is very important. 1 unit of FFP is 250 ml, and it contains all the coagulation factors. Complications are hepatitis. OTPT is more than SGPT because there is also a muscle injury due to dengue fever, and DIC, of course, and these are the neurological manifestation. All neurological types of manifestation may be there: meningitis, encephalopathy, seizure, stroke, mononeuritis, GBS, polyneuropathies, myelitis, myositis with rhabdomyolysis. We have seen all these complications. And of course, there can be an increase in amylase level. And on sonography, in up to 45% in one series, there was an increase in the pancreatic size. ARDS, acute onset, presence of bilateral infiltrates on the chest X-ray, and is the dreaded complication of dengue fever. Myocardial dysfunction, gram-negative sepsis, retinal vasculitis, and HLH. We should daily record the parameters which are basically related to coagulation. The Tony test is no more done these days, but you should look for these abnormalities. Physical examination, of course, vitals must be measured, and lab is you have to monitor the therapy by hematocrit, and of course, thrombocytopenia is worrisome for the attendants and for the patient also. That is the lot of pressure of using platelet transfusion without any scientific evidence. When to discharge: absence of fever for at least 24 hours, return of appetite, visible clinical improvement, good urine output, stable hematocrit, passing of at least 2 days after recovery from shock, no respiratory distress, platelet count of more than 50,000. So these are simple criteria to discharge the patient. And this is a little bit about prevention. Dengvaxia was licensed in 2015. And basically the efficacy is up to 57 to 61%. This is the pooled efficacy. Again, then too, it is only 35 to 42%. It is approved for use in dengue endemic territories for those aged 9 to 45, preferably seropositive individuals, and not for travelers to endemic areas. So this is a tedious job to determine who has a dengue seropositivity and other things. So it's really not very practical. And this is the article from NEJM. So what are the important summary points? Identify pre-shock stage by warning signs. Attempts to make early diagnosis by rapid diagnostic tests sometimes are not successful. We get variable results. Decreasing platelet and increasing hematocrit is unique to dengue fever. Leukopenia and anecdotic hepatitis are good predictors of clinical dengue fever. Prophylactic platelet transfusion does not improve outcome in non-bleeding patient. Overhydration is sometimes associated with ARDS. So you have to stop fluid when hematocrit falls below 40%. Drop in hematocrit with stable vitals denotes recovery, whereas drop in hematocrit, ongoing bleeding and unstable sign is worrisome. Overall mortality in dengue, severe dengue, should be less than 1% if we treat it timely. Thank you very much.
Thank you, Dr. Raman, for such an excellent talk, and really talking about the latest things, including the vaccine and the role of vaccine in dengue fever. I am sure everyone is going to be enlightened by this talk. There are a few questions in the chat box which we can take. And okay, one of the questions is how to treat resistant enteric fever and how long, and role of typhoid vaccine. Dr. Raman, would you like to answer that?
Yeah, sure. So basically, we are giving ceftriaxone is the drug of choice for enteric fever, but in certain pockets where resistance is there, salmonella resistance is there, we are combining azithromycin, of course, and duration averagely is about 7 days. And typho oral vaccine, I really don't think it is a part of the previous intramuscular vaccine. Also is not very effective, and is not usually included in the national immunization program. Typho oral was one oral vaccine, but the efficacy is really doubtful.
Yeah, I think that's a very nice answer. And we should remember that period of deference in enteric fever is 5 days. So we should not panic that if the fever is not coming down on day 2 or day 3, we should still continue the treatment. It will take around 5 days. There is another one, and primary care physician, how to approach a fever of 1 week duration, not responding to routine treatment. Dr. Subhash, would you like to answer that?
I would like to wait and watch 1 week fever, just baseline investigation, malaria parasite, malaria antigen antibodies, typhoid. By 1 week, I will get antibodies to the typhoid. So typhoid M, chest X-ray, urine complete, and most important, what is the TLC, DLC? If it is high, then I will think of amoebic, leptospira, or somewhere there should be sepsis or gout. And if the count is normal or count is low, I will think of viral infection, rickettsial infection, or rickettsial infection, viral infection. Leptospira is in leukocytosis. Leptospira, I will think of if there is leukocytosis. Yeah.
Thank you, sir. And I think as far as empirical treatment is concerned, ceftriaxone with doxycycline is the standard, gold standard for tropical fever.
2 gram, 2 gram twice a day. Ceftriaxone, right, 2 gram twice a day, along with doxycycline, 100 milligram twice a day.
Right. And if still the fever is not responding, we have to stop the antibiotics, send the cultures, and reassess as per PUO. Then is a UTI in females, how to treat. That is in most of the cases. Dr. Raman, would you like to answer this?
Regarding treatment of UTI?
Yes, sir.
Oh, okay. UTI in women and UTI in men, they are two different entities, and it's a very common problem. And of course, most of the cases, causative organism is E. coli. So it's usually not multi-drug resistant organism and easily responds to preferable nitrofurantoin that is orally available. And of course, E. coli, the previous IV, whenever there is IV requirement, ceftriaxone, Magnex was a very good choice once upon a time, but still we are using it. And this is a really new use of an old antibiotic. So a parental requirement is little different, but straight away we start patient with Viptas and all those neomeropenem, etc. But in simple cases, we should try oral antibiotics. Phosphomycin is another one which is quite effective in E. coli infection.
Another point they've asked is for how to avoid recurrence. I think the females should be taught about the personal hygiene and especially the toiletry hygienes that should be taught about. Ma'am, Dr. Renu, can you please answer the next question, which is why arthritis may present fever on 50% of patients?
Why? The fever may be because of the inflammatory causes also. So the inflammation can lead to fever because of cytokines, interleukin 6 and all. So the patient may present with fever in not in every patient, but the conditions I enumerated, they may present with fever. So inflammation always can cause fever.
Okay, thank you, ma'am. Another question, ma'am, you can answer is fever with pancytopenia, how to manage in patients who are non-responsive to paracetamol?
Fever with pancytopenia may be because of the SLE, or it may be because of the macrophage activation syndrome. So we have to consider these two conditions. Even in primary Sjogren's syndrome, the patient may present to us with these pancytopenia with fever. So these are the common causes, inflammatory causes of pancytopenia and fever.
I think the speaker wanted to know which drug to use for bringing down the fever in a patient with
depends.
pancytopenia.
It depends on the cause of the fever. And according to that, we can use. If the patient is having SLE, we will have to use the hydroxychloroquine and steroids.
I think, ma'am, he wanted to know because the paracetamol is not acting and we can't give NSAIDs. So the only option left would be maybe steroids in such a scenario.
There is inflammatory cause of fever with pancytopenia, and actually we will be using these steroids because paracetamol may not be able to decrease the fever.
Can I make a comment? Yeah, pancytopenia, basically, most of these days we find viral infections are very common. And of course, in our territory, we have a scrub typhus, which presents with leukocytosis and scrub. So there are infective causes of pancytopenia as well, but evaluation should be made whether the splenomegaly, lymphadenopathy, and all those things are there. And of course, if the pancytopenia is not responding, you should go for a bone marrow biopsy to rule out leukemias, etc. And of course, the treatment would depend on the severity of neutropenia. So you have to have introduce a neutropenic regimen in such patients. And sometimes we have patients of pancytopenia who have prolonged fever. So in that, empirical antifungal may be added. Thank you.
Next question is, what is the correlation between NLR and patient outcome? Dr. Renu, would you like to answer?
NLR?
Or
neutrophil?
Yes, ma'am.
Lymphocyte ratio?
Lymphocyte ratio, ma'am.
I think Raman will be better to answer this.
Raman,
Yeah.
Dr. Raman?
Yeah. This was basically NLR is present. This was an important indicator, particularly during COVID. If the lymphocyte count at the onset in COVID was less than 800, NLR was disturbed, more than 3.1 or something. So then it indicates a poor prognosis. So it's basically a prognostic marker.
Okay. I think,
Yes, sir. Dr. Hadra, sir.
Sir, unmute.
Sir, you are not audible, Dr. Hadra, sir. Please unmute yourself.
Yes.
Yes,
What
sir.
I was saying was, I was very much impressed by Dr. Renu Sehgal's comprehensive listing of causes of arthritis with fever. But what I thought would be very useful to practitioners would be a sort of diagnostic key approach. That means first you look for this, then if you find this, then do this, which ultimately will include all the causes. But otherwise, the number of syndromes which can cause both fever and arthralgia is tremendous. Therefore, step-by-step diagnostic track would be very useful to clinicians.
First is a good history and the from head to toe physical examination, and according to that, the investigations. If the patient has oral ulcers, we will go for the ANA, or if the patient has orogenital ulcers, we will go for the HLA-B51 and other histories. So it depends on the clinical findings and relevant infection.
Agreed. So we should construct a diagnostic key looking at these clinical findings.
Thank you, sir, for your observation remarks. I think most of the questions have been answered from the chat box. Dr. MP Singh, back to you.
Thank you, sir. I'm happy to inform the House that we were more than 100 participants, almost 125 participants during the CME. And we had a few overseas participants also, I think, for the first time. maybe the time has now come to have an overseas chapter of IACM. I'm extremely grateful to our guests of honor, Dr. PC Manoria sir and Dr. DK Hazra sir, who could spare some valuable time and bless the association once again. Please do join us, sir, in all our future CMEs. We'd love to hear from you. Thanks to chairpersons, Dr. B.B. Rivari sir and Dr. Dipanjan sir, who were a treat to watch and a lesson in how a chairperson should conduct himself. Thank you, sir, for being with us. Moderator Dr. Vikas Lumba sir and Dr. Kushwa sir also played their part to perfection. And it's my pleasant duty to say, and the sheer number of participants is an ample testimony to the fact that the speakers, Dr. S.C. Gupta sir, Dr. Renu Sehgal ma'am, and Dr. Raman Sharma sir were a class apart. The complex topics were made very simple to understand, the hallmarks of a great teacher. I'm reminded of the Japanese saying which says, better than 10 days of diligent study is 1 hour with a great teacher, and you are one of those teachers. Thank you, sir. And in the end, I'd like to thank all our past presidents, including Professor Dr. M.M. Singh sir, Dr. Hazra sir, Dr. Parikh sir, Dr. From Ludhiana, Dr. Avasthi sir, Dr. Madhu Chandakar sir. Please do join us and bless us in all our future CMEs also. And all the participants, you are the reason why these CMEs are considered. We'll try to make it more interactive. Your suggestions, comments, and constructive criticism is always welcome. Thank you, everyone.
More
And
power to you.
I'd like to have a
Thank you, Dr. MP Singh, for organizing this series of webinars.